Okay, so Dr. Lakoti and I are excited to talk about this topic today. We're going to be discussing hypotonia in the neonate, and this is kind of a perennially relevant topic to pediatricians and pediatric neurologists. So always happy and excited to kind of review this and hopefully give some tips and tricks on how to manage a hypotonic infant. We don't have any relevant financial disclosures. And our objectives today are going to be to define muscle tone and hypotonia, learn physical exam maneuvers that will help recognize hypotonia, recognize the difference between central and peripheral hypotonia, and then understand and recognize common diagnoses, specific diagnoses resulting in neonatal hypotonia. So first of all, what is tone? Tone is defined as the resistance to passive movement. And we think about both phasic and postural tone. So phasic tone refers to the tone basically in the extremities that is in response to movement. And so this is what we're assessing when you see us kind of wiggling and jiggling baby's arms and legs around. We're looking at their phasic tone. Sometimes we call this appendicular or peripheral tone as well. And then there's also postural tone, and that's the tone that is kind of inherent to our posture muscles. It's what helps with head control, maintaining an upright posture. And we sometimes call this central tone or axial tone as well. Hypotonia is a decreased resistance to passive movement. And it's important to distinguish hypotonia from weakness and hyperextensibility in your mind, because these are all different things. And while they can coincide together, you have to assess for each one in an individual patient to help clue you into what is going on. So while hypotonia really refers to the resistance to passive movement, weakness is a decrease in the power that can actually be generated by the muscle. And so you can have hypotonia without weakness. Likewise, you can have hyperextensibility without hypotonia. Hyperextensibility really refers to the range of motion of a joint. And so while it can be seen in hypotonia, it does not necessarily equal hypotonia. And as we'll talk about a lot throughout this lecture, hypotonia can be due to central or peripheral nervous system causes. And a lot of times our job is to try to find out where the hypotonia localizes to, and of course, what the underlying etiology is. So when you're examining a baby's tone, it's important to think about the examination in the context of the gestational age and the state of the patient. So premature infants are going to be hypotonic. We don't expect them to have the same muscle tone as a full-term baby. And even, people who are familiar with the Ballard score, that part of that score is actually seeing the kind of flexibility and the hypotonia that's normal for premature infants. So it's important to take that into account. Sleep also can result in hypotonia that's not pathologic. And of course, in the NICU and hospital setting, if a patient is sedated, then we really cannot take their hypotonia. We cannot say whether or not their hypotonia is related to sedation or an actual underlying cause in isolation. A few exam maneuvers that can be helpful to examine tone. One is called the scarf sign. This is where, as the examiner in the picture is doing, you bring the upper extremity across the chest toward the contralateral side. And in a patient with normal tone and normal term baby, you really can only get that arm to about the ipsilateral mid-clavicular line, whereas in a hypotonic infant, it'll come all the way across and wrap around like a scarf and go past the sternum. The traction response, I'm going to attempt to play a video here, is the most sensitive measure for looking at tone. And this, as you can see in this video, this baby has basically complete head lag at age of about 3 months. And so that is very abnormal. As the examiner in this video is doing, you want to grasp the hands and pull the baby from the supine position up to a sitting position. And even at term, there should really not be very much head lag. It is okay to have some head lag right at birth, but it shouldn't be this kind of complete head lag for very long. And shortly after reaching a term equivalent age, there should be really just minimal head lag. And ultimately by 5 months of age, the baby should keep their head in line with the body or lead with their head. Nope. Another exam maneuver that is very helpful is vertical and horizontal suspension. So for vertical suspension, that's shown in this picture here, we hold the baby kind of under their axilla, and we look to see whether they can maintain their posture without slipping through. If they can tire out, so if you hold them there for a few seconds, it is okay if they do tire out and eventually slip through, but their initial response should be like the baby in panel A here, where they have this flexion response, they're able to kind of maintain their posture above the examiner's hands. Whereas in panel B, on the initial suspension, they just kind of slip through, and that's a sign of hypotonia. For horizontal suspension, we hold the baby prone, kind of in midair with the hand over the abdomen. And in a normal infant, they should be able to keep their head midline. They should assume a flexion of the elbow and flexion of the knees. And be able to kind of keep themselves up, as opposed to the baby in this picture who is just kind of draped over the examiner's hand and looks very hypotonic. This slide is just a shout out to, this is, I think, a great website for both child neurologists and general pediatricians to be aware of. It's a website that goes over a lot of the pediatric neurologic exam, including all of these maneuvers that we use in the neonate. And it shows lots of videos and examples of normal and abnormal. So this is something to kind of keep in your back pocket. If you are ever assessing a patient with hypotonia, you can go and refer to this reference. So once you've used your physical exam to determine that a patient has hypotonia or you're concerned about hypotonia, what's the next step? Well, as with much of neurology, we want to try to localize as much as possible. And we're often trying to determine whether or not the hypotonia is most likely due to a central nervous system or peripheral nervous system cause. Well, how might we do that? Again, as in a lot of neurology and medicine in general, it's really important to go back to the history in these patients. And so while you may have already taken a history on your patient, there are some important pieces of the history that you want to go back and make sure you've paid attention to. So prenatal history is important. We usually do a good job of paying attention to, any serious complications and what the gestational age is. But you also want to ask about fetal movements in utero, whether or not there was a history of polyhydramnios, because these can be signs of weakness of both the extremities and weakness of swallowing and bulbar weakness that can be seen in neuromuscular disorders. You also want to ask about if there were any infections or exposure to toxins during the pregnancy, or any history of abnormal genetic screens during prenatal care. Around the time of birth, we want to know what the APGAR scores were. Did the baby make a normal transition into postnatal life? What was the timing of onset of hypotonia? Did the baby look good for a period of time and then become hypotonic? If they become hypotonic right when they start feeding, or kind of within that first 12 to 24 hours, that might clue you into an inborn error of metabolism. And particularly in the hospital setting, don't forget about sepsis. So if there is not a clear reason for a baby who's hypotonic, particularly if they also appear encephalopathic, the safest thing to do is to treat the baby as septic until proven otherwise. Going further into the history, particularly if for example, we're consulted on a patient who is hypotonic in the hospital, or has come in, a few weeks after going home and has been noted to be hypotonic. We want to pay attention to what other medical issues are going on. Are there other systemic issues, or is this just hypotonia in isolation? Like I mentioned before, is this a baby who's in the NICU and who's sedated? And that could be clouding the exam. Are there problems with bulbar and respiratory function? Is the mental status normal, or is the baby encephalopathic? How vigorous are they? Do they cry vigorously? Do they have a lot of spontaneous movements? Is there a history of seizures? And again, what has the pattern of progression been? Is it something that's fluctuating? Is it something that appeared normal at first and then developed over time? Is it worsening or static? Those can all be important clues to the etiology. We also want to pay attention to family history. So age of parents, history of consanguinity, if there's any history of infantile deaths or spontaneous abortions in the past, if there's a history of neuromuscular disease in the family, and because congenital myotonic dystrophy is a very common peripheral nervous system cause of hypotonia, are there cognitive issues in the mother or mild myotonia that can sometimes be seen in mom that can be a clue to the diagnosis. The exam is obviously also very important when assessing hypotonia. So we've already talked about sort of the tone exam, but I want to touch on a few things that are important in both the general and neurologic exam as well. So we always want to pay attention to head circumference, organomegaly, whether or not there's any dysmorphisms, a high arched palate, hip dislocation and joint contractures can be signs of neuromuscular disorders. And then poor respiratory effort that doesn't seem to be due to actual lung pathology or inability to wean off the ventilator can also be signs of neuromuscular weakness as well. On the neurologic exam, we're paying close attention to the mental status and looking for encephalopathy. If the patient is encephalopathic, that makes us think that the hypotonia may be more likely to be of a central nervous system cause. We look for weakness of the extraocular muscles and facial muscles. That can be signs of neuromuscular disorders. Poor suck and cry can be seen in both. In addition to tone and strength, the posture of a baby is important. So if they have that frog-legged appearance where their legs are abducted and their arms are just sort of splayed out to the side, that could be a sign of hypotonia even without actually feeling the muscle tone. And then again, we're really looking for strength here. And even though you're obviously can't grade a baby on the MRC scale, you can pay attention to their proximal and distal movements and presence or absence of anti-gravity movements in the arms and legs. Fasciculations can be a sign of a neuromuscular disorder, and then tendon reflexes can be helpful because for most neuromuscular disorders, they're going to be absent or low, whereas for most central nervous system causes of hypotonia, they're going to be brisk. So once we've done our history and exam, we want to try to localize the lesion. The most common cause of hypotonia is going to be central, but we can have a mixed picture. And again, it's important to not forget about those peripheral nervous system causes. So once we kind of determine what we think is most likely, we can proceed on with some more testing beyond our history and physical exam. If we think that a patient is more likely to have a central nervous system cause, we can do brain imaging, we can do EEG, we can do genetic testing for inborn errors of metabolism, and often patients receive kind of all of these tests depending on how severe the case is and how concerned we are. If you're more concerned about a neuromuscular cause of hypotonia, we can look at the CK level, thyroid function. It's important to remember to look at the heart because for several muscle diseases, you can have cardiomyopathy even at birth. We can do EMG nerve conduction studies in the NICU and in slightly older infants as well, and that can be helpful. Muscle biopsies can be done, less commonly nerve biopsies, but we could do it. And then again, targeted genetic testing, depending on the case, can be really helpful. We now have gene panels that can test basically if you think that it's a myopathy or a neuromuscular disorder that can test for basically all of the known causes of congenital myopathies, congenital muscular dystrophies, congenital myasthenic syndrome. So you can really get a lot out of using your genetic testing wisely. Interestingly, though, even though we have all of these tests that can be helpful, one paper found that just based on history and physical exam alone, 50% of patients were diagnosed successfully. And so it really is important to pay attention to all these factors that I've talked about, because that is really going to point you in the right direction in figuring out what's going on with a patient. And so an example of that is this patient who was a term baby, initially had, pretty unremarkable course, but over the course of the first 3 months of life was noted to seem to have developed hypotonia. So again, this is where that progression and that kind of decline in function was important. And when he came to attention, play the video here, he actually had started to have respiratory problems. But if you look beyond just the breathing pattern, there's a very alert infant here. I mean, he looks like he knows something is wrong, right? So he doesn't appear encephalopathic. He has a flat occiput, and so he probably has not spent much time moving his head. He was noted to have a weak cry on exam. He has this frog-legged posture rather than having a nice flexed and adducted lower extremity posture. And then his breathing pattern here is with a bell-shaped chest and accessory muscle use. And so based on history and physical exam alone, there was a high suspicion for spinal muscular atrophy. And that is what this patient ended up having. So that was kind of a quick whirlwind through localization, history, and exam of an infant with hypotonia. And so I'm going to pass it over to Dr. Lacodia, who's going to talk more about some specific common disorders that result in infantile hypotonia.
All right, I'll just assume that everyone can hear me okay. And moving on, I'll just spend a few minutes talking about some common causes of hypotonia. This is just recapping what Dr. Rogers just talked about in terms of central hypotonia. Really, despite what we're taught in medical school, that hypotonia tends to be a lower motor neuron phenomena. In babies, about 60 to 80% of the babies having hypotonia, the etiology can actually be central. Really looking at associated features with the hypotonia can be a key towards trying to figure out what is going on. With central hypotonia, oftentimes we'll see encephalopathy, seizures, their head size may be big or small, they may have facial or other dysmorphic features, increase to normal muscle stretch reflexes, clonus. Neonatal reflexes can be abnormal in both situations, central or peripheral hypotonia. With peripheral hypotonia, typically they will not have encephalopathy. Their mental status will be normal. They'll tend to have associated weakness. They do tend to be weaker than babies who have central hypotonia. Deep tendon reflexes may be low to absent, which can be a very important clue towards thinking about peripheral etiologies. But again, these form about 10 to 15% of babies that have hypotonia in the NICU or in the neonatal period. In general, this is just something to think about more for the residents, is that if the etiology is peripheral and it's secondary to a neuropathy, the deep tendon reflexes tend to be much lower out of proportion than the weakness, whereas with myopathy, the muscle stretch reflexes will be about the same as what you would anticipate with the amount of weakness. So when we're talking about central etiologies of hypotonia, infection, like Dr. Rogers said, is a big one. So until proven otherwise, sepsis is the most important cause. Meningitis, encephalitis would be big ones. Other important things that we can see in the NICU are toxin-mediated. So hyperbilirubinemia, hyperammonemia can be important causes. A lot of times, by the time neurology is called, the baby may have had seizures and may have received anti-seizure medications such as phenobarbital, which again can be a big cause for low tone. And then they may be on sedation if they're intubated or having other issues, which again can be a reason. Other important reasons to think about would be an acute injury to the brain, such as hypoxic ischemic encephalopathy or ischemic or hemorrhagic stroke. Chromosomal abnormalities also form a decent proportion of central hypotonia. And then a smaller proportion is metabolic diseases and brain abnormalities. In terms of peripheral etiologies, even though the list is pretty long here, they do form a smaller percentage of neonatal causes of hypotonia. Really, again, when we're thinking that the etiology is peripheral, thinking through the neuroaxis from the anterior horn cell to the muscle helps you localize what the exact etiology might be. So in the next few slides, I'll just focus on some of these things that I've highlighted, some of the common causes of central and peripheral hypotonia. This again is from a paper from Neo Reviews that looked at causes of hypotonia in babies. HIE and chromosomal abnormalities formed a big percentage. Brain anomalies a smaller percentage. And then in about 13% of the cases, the etiology for hypotonia was unknown. So looking through the neuroaxis again, when we think about the central nervous system, we kind of mentioned acute insults such as HIE, strokes, as well as infection and toxin mediated. But then thinking about chromosomal abnormalities, these are some of the common etiologies of chromosomal issues that can lead to hypotonia that may be seen in the NICU or in the neonate. A lot of the common things within these syndromes is that they may have very specific facial dysmorphisms. And there may be also associated features such as in trisomy 21, you can have congenital heart defects. Autism is much more common in patients with Fragile X syndrome. Intellectual disability may or may not be seen if the etiology is chromosomal abnormality. Again, with chromosomal abnormality, you see hypotonia, but you won't necessarily see weakness, and your muscle stretch reflexes will tend to be normal or brisk. The second thing that will, within the neuroaxis, if we come to peripheral, the first one would be motor neuron, and spinal muscular atrophy tends to be a common cause within this. Even though it's a more common cause that we think of with the floppy baby, SMA is only about 2% of neonatal hypotonia, so about 1 in 10,000 live births. So SMA is an autosomal, 5q SMA is an autosomal recessive condition where you have a non-functioning SMN1 gene or deletion of the SMN1 gene, which is needed for survival of motor neurons. So you really depend on this backup gene, SMN2 gene, which makes a little bit of the protein that is required. If you have more copies of that SMN2 gene, your disease tends to be less severe. So there's different phenotypes of SMA depending on what the severity is. We don't need to go through this whole list of all the types of SMA, but typically in babies, the classic forms of SMA that we might encounter are type 0 or type 1 SMA. A baby with type 1 or infantile onset SMA is that classic floppy baby that we think about, who may have been born normal, was doing fine, and then had regression in the first few months of life, motor regression, classically. Also called Wernicke-Hoffman disease. It forms about 80% of SMA. This is just an important condition to think about right now for general practitioners because SMA is now in the newborn screen for most states. So it will be something that you'll come across within your patient population. And there are disease modifying therapies. So early intervention is really important. The diagnosis can be made by, again, history and physical exam can clue you in towards this diagnosis, but then there is genetic testing that can be done that would be looking for a deletion of on the SMN1 gene. These are some examples of babies with SMA, which again, you can see that frog-leg posture. The baby is very alert, has that bell-shaped chest and accessory muscle movement. The bell-shaped chest is because the diaphragm is spared in terms of weakness, and intercostal muscles are more involved. And you can see that even though she's trying to move her arms and legs, she really can't lift those up anti-gravity and bring them up. Kind of the same thing here, that the baby is very alert and looking around. There is no encephalopathy. And she's trying to move arms and legs, but really can't lift those up anti-gravity. This is not specific for SMA, but it basically is an example showing that there's weakness also going on. Moving on, I didn't have anything for the nerve here, mostly because those are very, very uncommon causes where you might see hypotonia secondary to hereditary neuropathy. We'll focus on the neuromuscular junction next, which is something that may be sometimes that you can come across in the NICU or in the early infancy. So one important thing to think about is transient neonatal myasthenia. What transient neonatal myasthenia is that mom has myasthenia gravis, and because mom has antibodies, those get transferred to the baby. And because babies get those antibodies from mom, they might have transient weakness and may have respiratory issues, may have bulbar weakness or trouble feeding. But as the name suggests, it is transient. It does get better over the next few weeks. And really treatment for these babies is just supportive. They do recover completely. But this may be something that you come across if mom has myasthenia gravis. Congenital myasthenic syndromes are different from myasthenia gravis. These are a much rarer group of disorders that are genetically mediated, and they can have different features such as eye muscle weakness, ptosis, bulbar and respiratory muscle weakness, as well as in more severe cases can have apnea and arthrogryposis, which is joint contractures. Infant botulism is an important cause of hypotonia to think of in infancy. Typically presents within 1 week to 12 months of age, but really 95% of babies will present less than 6 months of age. It is mediated by Clostridium botulinum toxin. There's ingestion of spores that happens, and because of the ingestion of spores, there is an exotoxin that causes presynaptic blockage at the neuromuscular junction, which leads to progressive weakness. So your classic features that the baby might present with will be constipation, poor pupillary response, lethargy, poor feeding. And then this is the classic descending hypotonia where you might see bulbar weakness and hypotonia first and then progressing to the body. Muscle stretch reflexes will be hypoactive to absent. The diagnosis can really be made clinically based on history and exam, but there is exotoxin testing that can be sent in the stool. And treatment really is supportive, but baby big, which is the immunoglobulin, can help fasten that recovery. But these babies typically will make complete recovery. It may take many weeks, sometimes even months to recover. But during that acute period, they can have respiratory failure. So that is an important thing to think about and monitor for. Coming further down in the neuro axis, the last part is the muscle. One thing that may be, from a muscular standpoint, one thing that may be seen in the NICU rarely is congenital myotonic dystrophy. This is a form of myotonic dystrophy, which is mediated by CTG repeats. And what the babies might present with would be, again, reduced feeding movements, joint contractures, weakness. This might be the typical baby in the NICU that has respiratory failure and has an inability to wean off the ventilator. The diagnosis, suspicion for diagnosis can be made by, again, history and physical exam. There may be myotonia in the mom or cognitive delay in the mom, and the baby might have hypotonia, this classic facial diplegia where you have tenting of the upper lip and open mouth like it's in the picture. Again, not pathognomic for this, but again, suggests that there is weakness going on. And then confirmatory testing can be done by genetic testing these days. Sometimes we may do a EMG also. So really, ending this talk with that, as with anything else in medicine, history is extremely important. As with anything else in neurology, exam and localization are important. And unlike what we were taught in med school, hypotonia can have central and peripheral etiologies, where in babies, central hypotonia tends to be a majority of the etiologies. And that is it.